Lola, can we start?
Okay, sir. Yeah, good evening, everybody, and thank you for coming in. Today, we'll be talking on integrated and interdisciplinary teaching of physiology in Nigerian medical schools, a curriculum innovation proposal by Dr. Cordilia Iyare. Dr. Cordilia Iyare is a medical physiologist and a university lecturer whose work centers on reproductive neurophysiology and the developmental program of disease. Our research investigates how perinatal insult, prenatal stress, endocrine disruptors, and adverse intrauterine environments disrupt neuroendocrine pathways that regulate reproduction, with particular emphasis on long-term reproductive and metabolic health in women. Through the use of electrophysiology, neuroendocrine assays, developmental animal models, and translational approaches, she explores mechanisms linking early life stressors to altered hypothalamic pituitary gonadal axis function and reproductive dysfunction. Dr. Iyare earned her PhD in medical physiology from the University of Nigeria. Prenatal arsenic exposure from calcium carbide ripened fruit leads to impaired pregnancy, outcomes and programmed infertility in female offspring. Her earlier postgraduate research examined botanical and metabolic modulators of reproductive and developmental physiology in diabetic and stressed pregnancy models. She has published widely in areas spanning perinatal stress, phytomedicine, neuroendocrinology, and developmental toxicology, contributing over a dozen peer-reviewed articles. She serves as a lecturer at the David Umahi Federal University of Health Sciences, where she teaches medical physiology, mentors undergraduate research, and contributes to curriculum development. In addition to her academic role, Dr. Iyare is the program manager of the Mountain Movers Vulnerable Support Initiative, where she designs and leads community-based interventions for vulnerable population. She has extensive editorial experience, having served as managing editor for multiple biomedical journals between 2014 and 2023. Dr. Iyare is an active member of several professional societies, including the International Society for Neurochemistry, American Physiological Society, the Physiological Society UK, Neuroscience Society of Nigeria, and the International Society of Developmental Origins of Health and Disease. Our research contributions have been recognized through awards such as the IUPS Germany Travel Grant 2025 and AAPS ESP Travel Grant 2025. Guided by a long-time vision to establish a leading research group in female reproductive neurophysiology and developmental origins of infertility, Dr. Iyare is committed to advancing African research capacity, promoting scientific training, and generating knowledge that improves maternal and reproductive health across lifespan. And you're welcome on board, Dr. Iyare. Welcome, ma.
Thank you very much, Madam Evelyn. It's a privilege to be in our midst today. I hope you can hear me clearly.
Yes, we can.
Yes. Okay. Okay. Oh, thank you. I want to thank Professor for giving me the opportunity to speak on some webinar. It's an honor for me, and the previous webinar talk is co-authored by Professor Abdulatif Alongbosi is here with us. Knowledge is here. So without wasting much time, we'll just go see my screen. If you can't, you can let me know. Moderator, is the screen visible?
No, ma.
Okay.
It's not.
Yet.
I guess it's the network. It's still loading. Maybe we should just give it some time. It will load.
Okay.
So you can share again. It has stopped
Yes,
sharing.
that's what I'm doing now.
Yes, we can see
Is
it
it
now.
vis
Oh,
okay,
it's
it's
gone
visible
again.
now. Okay.
But it's gone
It's
again.
gone? Oh, uh-oh.
It just came on and then.
Oh, sorry for this. I thought all of this was under control.
Can you send it to me by email?
By email.
Yeah. Maybe I can share from here. While you are still trying
Okay.
to share, if you have challenges, I can also share.
Okay. Teaching of Physiology, Nigerian medical schools, a curriculum proposal co-authored by Professor Alagbosi. Proposal we presented last month in the FISOC teaching conference, and I felt honored to also share it with Professor Oyele reached out to me. And so by way of background, physiology remains central to medical training because it explains normal functions that underpin.
So it's something that is not really fair for. Okay.
You can't hear me?
No. Please mute yourself, please. Continue. It's not related to you.
Okay. Okay, so physiology explains normal functions that underpin disease mechanisms, diagnosis, and treatments. So it's sometimes taught as that students must apply across systems and clinical contexts. And integrated curricula, which we are proposing, attempts to connect subjects that are separately with horizontal integration that will link disciplines like physiology, anatomy, biochemistry, and sciences over time, clinical and spiral integration that revisits concept with increasing complexity. So CCMAS makes this proposal quite timely because it replaced the old BMAS framework that we used to use and gives Nigerian universities room to modernize teaching through shared national core, and that's for 70%, and then the 30% institutional innovation space. But most times in our institutions, the 30% space, it's seen as time for extra topics only, and which is really not so ideal. So we can actually use our 30% strategically for integrated case seminars, clinical reasoning activities, low cost practical demonstrations, student-led concept mapping, formative assessment, and interdisciplinary teaching blocks. And before people, we don't look at this because we feel physiology is just, most times when people graduate, they just seek other things. But with new we got a news recently that Nnamdi Azikiwe University, in collaboration with the teaching hospital, now physiology students for internship. So I think the need arises now for physiologists to clinical trainings, even while undergoing the discipline in school. You cannot just send people for internship without first exposing them at that initial stage. So, in a resource limited preclinical physiology context, students value case-based learning for active participation, conceptual clarity, knowledge retention, and early clinical reasoning. But the implementation can be affected by time, limited time, inconsistent facilitation, restricted clinical exposure, and then lack of visual learning resources. And we all quite agree that most of us, during our early days of training, we were not really exposed to all of these things. It was quite didactic learning and teacher centered style. So now the core problem is a gap between physiology teaching and clinical application. Students may pass physiology examinations and they struggle to even explain patient problems. It's for them, it's just a higher biology, which shouldn't just be. They can't explain, they can't correlate what they learn in classroom and what they see, the cases they see in everyday life. There's no correlation. So this can be bridged using integrated mechanisms. So traditionally, delivery often separates anatomy. Traditional delivery rather often separates anatomy, biochemistry, physiology, pathology, and even clinical medicine into different timetable spaces, creating repetition in some areas and serious, massive disconnections. And then you treat them as separate discipline, no connectivity. This was solving an interdisciplinary collaborations. So the refined proposal therefore shift the intervention from more teaching methods to a structured systems aligned curriculum change, link learning outcomes, link teachers, assessments, and then evaluation. So the aim for the proposal and then evaluate a context that is model, the teaching model that is aligned with CC mass for Nigerian medical and health science institutions. And some of the core and specific objectives include map selected physiology topics, identifying where horizontal, vertical, and interdisciplinary integration used without bridging existing credit structures, develop and deliver physiology, more like a pilot study, using cardiovascular, respiratory, renal, and neurophysiology team. We'll not just go all through the various modules, just pick the four first to start with. And we use case-based learning, modified problem-based tutorials, concept mapping. You have the think, pair, share, think, you individually the think, and then they pair to reason out what they've taught, and then they share before everyone. Then guided clinical demonstrations, and then low-cost digital tools to improve applied understanding. Assess changes in students conceptual knowledge. We can assess their change, check their applied physiology performance. We can also check clinical reasoning and engagement using validated instruments. And then we evaluate the feasibility, the acceptability, both by the students and then the faculty members, the tutors. Then fidelity, the scalability using student feedback, faculty feedback, implementation logs, qualitative interviews to see if it's actually doable. Okay, and then we generate a practical implementation guide that can be adopted by physiology department across Nigerian universities. Now though we have the CCMAS that guides us all in our various institutions, but you see there are some peculiarities in different institutions as to what they actually do, what they teach in physiology. So you come out without a harmonized let me just say teaching skill for all physiologists. You don't see a doctor and say, "Oh, is this UNN trained? Is this Unilorin trained?" Because I can see gap, knowledge gap, and all of that. No, they have a standard and they are all trained that way. But in physiology, you hear of some doing clinical physiology, some are not really into clinical practice, some know nothing at all about clinics, and we all come out as physiologists, same 4-year course. So we need to have a standard, we need to have a practical implementation guide that should be adopted by all physiological departments across Nigerian universities. It should include clinical teachings. And so the methods to be used is a mixed methods, quasi-experimental educational intervention study. It will be used for the quantitative component to compare students' outcome before and after the implementation. Then the qualitative component will explain how students and faculty experience the intervention and what barriers affected delivery and what adaptations are needed for scale up. Of course, a mixed method design is appropriate because curriculum change is a very complex educational intervention. The preferred design is the two cohorts comparison. We'll have the previous, or we'll have a current cohort taught mainly through conventional discipline-based methods, and then the parallel cohort will be taught using the integrated physiology model for these 12 weeks. And we'll have two comparable classes, where one class will receive conventional teaching and another integrated teaching during the same semester, with ethical access to learning materials provided to both of the groups after data collection. The pilot will be conducted, of course, in my school for now. We can have other multi-center pilots study federal universities, state universities, and private universities later on. So participants will be clinical medical students, 200 level precisely, 200 level second year MBBS students. Because my school, we do not have BSc physiology at the moment. So we'll use the second year MBBS students, so equivalent students in physiology heavy programs, when other schools also key into it for the pilot study. And we chose 200 level students because they are early enough in training to benefit from basic clinical integration. And so for the inclusion criteria, students registered enrolled in the selected physiology modules will be included, attendance 75%, and consent to the learning materials and feedback data. Those who differ, those who withdraw, those who fail to complete the baseline or endless assessments will be excluded. So 150 to 300 students will be utilized for this pilot study. And for the qualitative work, we can have 4 to 6 focus groups of 6 to 8 students each, and then 8 to 12 faculty interviews will be sufficient for depth and variation. The intervention, like I earlier said, would run for 12 weeks and will be organized around 4 physiology systems. And each systems will include a shared case, short core lectures, integrated seminar, small group or modified problem-based learning activity, formative quiz, clinical reasoning debrief. And this is the table of how the 12 weeks will look like. We have the first 3 weeks, we'll do cardiovascular system, 4 to 6, respiratory, renal, and then neurophysiology. So the core physiology focus outlined, then the integrated partners will need partners from anatomy, biochemistry, pathology, pharmacology, and then the medicine, maybe internal medicine physicians who come for the clinic, for the case-based studies, and then the clinical aspects of each of these systems, how they present in clinic. And then students' activity, the BPKs, the ECG demonstration, concept mapping will be done by the students. When they do these things by themselves, they learn on the job, they understand it better when they begin to map out these concepts by themselves. So this is going to run through for the 12 weeks. And each of the teaching methods have been outlined, and the case-based learning, modified problem-based learning, interdisciplinary co-teaching. For under the interdisciplinary co-teaching, each system will have at least one co-taught seminar involving a physiologist and other discipline. Where physical co-teaching is not possible, we will have a recorded mini input from clinicians or other basic senior lecturers will be inserted into this section. There are some schools where, due to lack of staff, you may have to get recorded teaching mini inputs from clinicians either far away, and then played for the students just an hour or less to blend the learning. So low cost active learning is also the focus. It has to be low cost, otherwise it will not be feasible, it will not be sustainable. The intervention, we use think per share, 1 minute papers, concept mapping, pair explanation, even image interpretation. We can just have pictures and then they are projected. If the schools are not exposed to internet facility, will not have internet facility, we can have them downloaded and then projected. Okay, so we can have an EEG graph sheet projected, and then the students try to do the interpretation. So these strategies are chosen because they require limited infrastructure, but they create interaction, they create feedback and retrieval practice. So for blended support, we have digital support will not be intentionally modest. The digital support will be intentionally modest. We'll have Google Forms and paper quizzes. Those are quite affordable. And we can have WhatsApp class prompts, downloadable PDF, short audio notes, recorded micro lectures where available. But it will not replace the main learning. It's just to support. It's just a support for the proper one. Then the faculty preparations, as for the faculty preparations, before we start off fully for the 12 weeks implementation phase, the lecturers and the facilitators, we have to attend a 2-day faculty development workshop. Workshop will cover CCMAS mapping, principles of integration, writing simple clinical cases. The lecturers will be taught that, then facilitation skills. Where we do not have enough lecturers, you can incorporate the postgraduate students to also facilitate the groups, and the use of formative assessment as well. Feedback methods and completion of fidelity logs will be taught, and a shared facilitator guide will be produced for each system, so that cases are delivered consistently even when multiple lecturers are involved. So we'll have a guide, a facilitator guide that will follow. So the assessment strategy will be aligned as will not deviate from the CCMAS outcome and the intervention objective. So the aim is not only to test recall, but also to test applied understanding and reasoning by the students. We'll measure the ability to apply mechanisms to problems, support learning and identify difficult concepts very early, assess applied interpretation skills from the student, to assess sustained understanding too, sustained understanding by the students as well. And then the evaluation plan will use a modified Kirkpatrick model because it can capture learner reaction, learning, behavior, application, and broader educational results. For time's sake, I won't focus on this. So for data collection instruments and quality assessment, assurance rather, the curriculum mapping template will align each teaching week with systems outcome, physiology, content, integration, partners, teaching activity, and then the assessment item. The knowledge and the applied reasoning test will be reviewed by at least 3 subject experts for content validity, and the item difficulty and discrimination will be checked after administration. The student perception questionnaire will be piloted, and internal consistency will be checked. Focus group guides will explore perceived benefits, barriers, the workload. We shouldn't overburden the students because we are trying to profile a better way. And facilitation the quality will check as well, realism of cases, and their recommendations for improvement. The faculty fidelity logs will record section delivery, attendance, topics covered, adaptations, time used, barrier, and then resources required. Of course, we'll have a lots of analysis, both quantitative, qualitative analysis, and then there'll be an integration of the findings. For the quantitative and the qualitative results will have to be integrated during interpretation. For example, if a test score improve, but the student workload concerns are high, the final implementation guide will adjust. Case length, timetable spacing, and facilitator support. And ethical considerations will definitely be put into will be first priority. The relevant institutional research ethics committee will be utilized. Data will be stored. For the expected outcomes, we believe it will improve student ability to explain physiological mechanisms using clinical and interdisciplinary examples. There will be better performance in applied physiology questions and case-based reasoning tasks. And there will be improved engagement during large class teaching through structured peer discussion and formative feedback. We'll have groups of 10 to 15. Just have groups of 10 to though our classrooms are not designed that way to have like roundtable discussions, but we can just have students cluster together, 10, 15 cluster together, and then with the case-based reasoning or problem-based learning, we have each group begin to tackle a problem together, and make sure everybody is involved. The facilitators will be there as well to help. Greater faculty collaboration across physiology we believe this will be definitely it will call for great collaborations among physiology, anatomy, biochemistry, and all the other clinical departments as well. And then a tested CCMAS aligned implementation templates that other Nigerian institutions can adapt with limited resources. So we have the feasibility and risk management for large classes. It's likely there'll be limited discussion and feedback. So, and then there's still the mitigation plan. We can use groups of 10 to 15 pair facilitators, even class representatives as well, and then structured worksheets to ensure everyone is busy. And yes, we know there may be the risk of faculty resistance or workload. Lecturers will complain, it may be an added workload. No one wants extra work for no increased pay. And the likely effect is that there'll be poor implementation or fidelity from instructors or from lecturers. But for the mitigation plan, we can start with 4 systems only. We must not do a complete overhaul. Just start with 4 systems. Okay, start with 1 system. Provide ready-made case packs. Recognize co-teaching as departmental service. So I think it's time we need to understand that when we co-teach, it's a departmental service. It's not. It's something we should do. We should always work towards getting results, effective results, better outcome. And if this will bring about better outcome, then we'll see it as a service to the department. And then timetable rigidity. If there's difficulty in scheduling joint sections, then we can use just one integrated seminar per system. Just one integrated seminar per system instead of doing it maybe weekly. We can just have, for the entire cardiovascular system, we just have one integrated seminars where we'll have co-teachers. We have those who co-teach and they explain through the process, and they embed cases even inside existing physiology hours. We can embed cases where the cases will be discussed. Just a very flexible style of teaching, with the intention of having the students be at the focus, be at the center, not just teacher teach, throw the cases to the students, incorporate it into what we already have, our lecture notes, just incorporate these cases in between, and we believe it will flow. Yeah, there may be limited internet or equipment, and it is this likely unequal access to digital materials. So for something like that, we can provide offline materials, offline PDF, projected images, like I earlier said, use digital tools just to support. We can download these materials, download these cases, or write them out on paper like we normally do in teaching workshops. You have large drawing sheets, and then you just begin to do the concept mapping on paper, on large drawing sheets, and 10 to 15 can go around and begin to have inputs on that sheet. Everyone is with a marker, everyone is with a pencil, everyone is having their input on the paper. These are offline materials. And so we also have the risk of assessment misalignment, and students may ignore integrated activities. Usually those at the back will not want to participate. But when we have groups and clusters, it means there is no back, there is no front. We just have round table. When there's a round table there's actually no need for a high table. So just go around and round, and then the lecturer have to know that it's not to sit at the front and look like in the church style. You move around and see those who are working, those who are active, and those who are not involved. Okay. And so for variable facilitation quality, we may have uneven student experience. So but when we use our facilitation guides, short training, and we have to time it as well, it shouldn't be so lengthy and boring. Short training, and then for the fidelity checklist, we will believe this will work. And of course, we'll also look out for challenges during the pilot study. The timeline is going to take like 26 weeks. It's going to take like 26 weeks. So we believe the integrated and interdisciplinary physiology teaching is feasible in Nigerian medical schools when it is designed as a systems aligned, context sensitive, and resource conscious intervention. And the proposed model will use existing curriculum structure, but it will improve how physiology is taught, how physiology is applied and then assessed. And by combining horizontal integration, early clinical linkages, case-based learning, low-cost active method, and structured evaluation, the proposal will provide a practical route towards stronger conceptual understanding, clinical reasoning, and graduate readiness. The model can be piloted in one department, refined using evidence, and then scaled gradually across Nigerian universities. So for time's sake, I just skipped an illustration. So I will want to talk about that. Like for cardiovascular physiology, for example, we can have the physiology introduce the concept and allow the students do the mapping of the concept. They map it out. They know the principles involved in blood circulation, in blood flow. They understand the concept, and when the physician done with the mechanism, done with the concept, we can also have an anatomist come in and explain the structure of the heart. It's 20 minutes for a 2-hour lecture. We can see of the heart explicitly, and when we are done, we're done with the physiology aspect, we're done with the anatomy aspect. Then we'll now have a pharmacologist who can talk on before even the pharmacologists have the pathologists who talk on the diseases of the heart conditions, disease states, and the pharmacologist come and talks about the drugs. They may not be present in person. We can have them recorded. We can have them give a recorded sections. This was possible. I think was this something last month. I had a revision section with 200 level students, and I had to incorporate Professor Alabosi, who is not in Nigeria. It was a Zoom section, and thank God it was a revision section, so they were at home, and everybody had access to internet facility. Professor Alabosi had to speak to them on something that he has an authority on. I didn't have to say, let me go ahead and speak on this because I'm the lecturer or the course coordinator. So he came and spoke on it. And I saw active participation when they saw someone else was talking with even more authority, in quotes. And he even brought his suggestions and then gave them access to the God Digest game that he had designed. I saw active participation and active learning. Everyone was trying to answer the question, drop their feedbacks. Just within the space of an hour, 30 minutes or 2 hours, I saw I saw response from students that we don't get when we just do our normal general teaching. So ever since, I was beginning to look at how we can scale up something like this. What if there was no internet facility at that time? Maybe it was done in school. I can have Professor Alagbosi give a video record, send it to me, I download it, and then from my laptop, definitely we have light, and then I can project it, and then in school they can watch it, and it's as if he's talking to them directly. So these things enhance learning. The entire purpose of this proposal is not um for me, it's not for the benefit of the lecturer, it's for the benefit of the students, to have people who come out sound, who can come out with their chest up and say, yes, we finished, and we finished well. So I will stop for now, and hope to entertain questions. I want to believe we followed up onto these moments. Moderator, over to you.
Hello, Miss Somolola. Are you there? Thank you for a brilliant presentation. Our moderator is still muted. I hope she's online. But that has been a brilliant one. Omolola, can you?
Yes, sorry, it's the next one. Yeah. Yeah, thank you, Dr. Cordilia. And this was very fantastic. You actually really did a good job. And I hope from what we've had, we'll be able to incorporate, like you said, and get to do the needful. The platform is opened for anybody who wants to ask Dr. Cordelia any question based on the webinar she just presented. Please, you can signify by raising up your hand and we'll call you to ask your question.
Thank you. While people are thinking about asking their question, I've appreciated our presenter. And then I think this plan, this approach, teaching method looks so fantastic. I remember that she presented this at the Physiology Society meeting in London, Newcastle, right? And people were asking, as you said, we hope this will be practicable. This looks very big, very innovative, and in our climb. Do you think it is really, really doable? I know you have given the example of Dr. Lagmasi speaking and what have you, but in reality, what do you think we need to do to be able to incorporate this type of teaching, and not just in one university, maybe at least spread it around in the first instance? Some good, don't ever think that some private university cannot do good, or they actually have some infrastructure that some federal universities may not have. So what would be like a sample size or trial range that you think can improve over time?
Okay, thank you, Prof. First of all, it's doable. It's doable. When it was first presented, the questions I was asked is, do we have the manpower? Do we have capable hands? Do we have such collaborations among faculty members to do something like that? Because if you look at it from a distance, you think it's an extra workload for a lecturer. But those who have been doing it, the people that came and asked, I had to also ask them, as they asking me questions, I was asking them questions, how do you run it? And they actually confirmed that it's not an extra workload. It's not extra. So something that a teaching that you should do for 2 hours, you just go and do your 30 minutes beats when you're done with the concept introduction and the mechanism talk. You're done with your part. You're done. If you choose to even stay back, you can, or you want to just walk away, you're done with your 30 minutes part, and then the next person comes in. So first of all, it will foster collaborations among the faculty member. We'll have to first of all agree that this will help the students. This will help the student, and then we'll be ready to give this change a trial. It's not going to take much of our time. We already have biochemistry around us. We have anatomy around us. It's just to sit down and work on a faculty timetable. So we started that in my university. What we did, what my head of department did was to pair up lecturers. But because we had not even introduced it to the other sisters department, so she had to pair up lecturers. So she'll pair up a physiologist. A physiologist starts, and then she pairs it up with a medical doctor who is also a lecturer in physiology to speak on clinical cases and all of that. So she did a pairing. We started that way. But now it's even just gone beyond just physiology. We need to also integrate the biochemist. When you are talking about the brain, for example, you may not even have all the authority to speak on biomarkers where a biochemist is. So when we have a faculty timetable, we need to have like one timetable where the biochemist has to come in and speak on these things. for me, it's very feasible. I've seen it with my mind eyes that it will even be more interesting for the students. The reason, like I discussed earlier with you, is because students begin to see that these things are different. They see the body as one, but they see the systems as different. Sometimes when you discuss the systems as if they are not part of the body, and they'll say, no, this one is just only on GIT. Let's leave neuro first. But they are all integrated. Okay, we are talking on blood. Let's just leave CVS first. But they are can you really write on food absorption without also talking about blood supply, without talking about the integration of the higher centers and its influence? So there's this whole in so students need to know that when we are talking on this, there's a connection, there's a link, there's a connection. And if we believe, first of all, that it's established that there's a connection and there's an integration, a part that is made a whole, then we, the faculty members, should also know that we too have to come together to teach a system. We cannot just leave one system for an anatomist or one system for a biochemist or one system for a physician. We have to come together to teach that system. If we agree, it will work. It will
Okay,
work.
okay, okay, Doc.
Yes.
I know you are passionate. If we leave you, you continue to speak for the next because you're like, yeah, you're passionate about this. I do know that even the CCMAS is integrative in nature. Like at University of Learning, where we are, when you are teaching respiratory system in physiology, you're also teaching that in anatomy. You're also teaching that in physiology. In fact, that is in the early days, you actually do like the progressive assessment. You are served 3 papers and you are writing anatomy and physiology and biochemistry the same time, 3 hours, until about 10, maybe like 8 years or 10 years ago, when you can now write anatomy exam on a different day from physiology, but the teaching is still sort of integrated. And I know that you are taking this ahead, and you have said, okay, we are going to do 30 minutes, you can do 30 minutes, other people can come in. But sometimes, I don't you think that sometimes it might be easier said than done? And then the student you are dealing with, are they really ready for these changes? In terms of, well, some things are easy, they are happy, but when you now come to the examination, are we ready to also change the examination pattern to favor this kind of teaching? It's just a thought.
Oh, okay. Whereas for the examination pattern, I believe if we are adopting the system, of course, we also have to adopt a slight change in the examination pattern. The emphasis now here is on bringing early clinical exposure to the students, early clinical exposure, so that when they go over to the clinical stages, they don't have it's not new. So even in the exams, we may not have them go to the hospital to have clinical cases and they speak, but even in the questions, in the way we set our questions, they have to be clinically oriented, not just define this. You need case questions that are clinical in nature. Even in our school, we are being asked, when you are setting questions, theory questions, or even MCQ, make sure they are clinically oriented. Make sure it's not define cardiac cycle or what are the stages of no, you just bring a case where in that case they can have the definition, they can tackle the case, they can begin to investigate what disease states can arise from this and that, or even with figures they can tell, okay, is this are we dealing with anemia here, are we dealing with this? So the exam questions too will also change. It will start with us, the change will begin with us, the faculty members. And there's something I didn't add to this proposal, which I learned from that conference, that things like this should be co-created with students. That concept like this, innovations like this, the students should not be left out in the creation of it. Or most of the conference presentations, we saw tutors, students co-creation, even modules, syllabus. Students were part of the creative process. They will even tell the lecturer, this is how it will be better delivered. And they were applauded. But I know that it's not what we do here. We don't need them to come in when we are creating something like this. But when you actually bring them in, I believe it will also strengthen it. They will see what is coming. They also decided, they spoke, and then there was an agreement. Then they too also rise up to the change.
Thank you.
We'll
I
do the
think
pilot
moderator,
and then we'll find out
moderator can.
what will come out of it.
Thank you. I think other people can ask questions. I have one more question, but when other people have asked, I hope people will ask. Thank you, Dr. Iyare.
Thank you, sir.
Yeah, thank you, Dr. Iyare, for the response. Please, is there anybody on board that still want to ask Doctor any question? Please, you are free to ask.
Okay, thank you, Dr. Iyare. Good evening, Prof. and everyone. I enjoyed your lecture. I just want to know if at this point, do we have that kind of relationship with our sister department? Because from this topic alone, this is interdisciplinary physiology teaching. When anatomists see this, will they not think, are you trying to co-opt us into what you are doing, or you are trying to bring us equally into this uh, new teaching style? Because sometimes me are looking at it, they will feel as if, okay, are you trying to just bring us in, or we share in the same. I don't know if you get what I'm trying to say. That's first. And the second thing is this: it's very great for medical school, being that the students will still do pathology, pharmacology later in medical school. But if we bring this into the physiology context, do you think it's possible in physiology now, after your trial, after the first pilot test in your school, do you think if we bring this to the University of Ilorin, for instance, we have pathologists from UITH who will come to the physiology department to come and teach? Do you think we have neurologists coming from UITH and teach? How possible would this be in the context of physiology? Thank you very kindly.
Okay. Okay, thank you very much. So your first question, do we even have that relationship? I believe relationship can be initiated. We can always start from somewhere. And it's not in us to go ahead and foster the relationship. It has to come from the higher authorities, the higher centers, the faculty have to see and then agree that this will work. And then we'll begin to, for me, if the anatomy, for example, or biochemistry is not ready, but when there is an impulse from the higher centers, everybody have to align with good reasons that this actually will work. Yes, this is for physiology. I'm speaking as a physiologist, so I just wrote, yeah, interdisciplinary teaching of physiology. If the anatomy also feel there is input, okay, what about for anatomy? Should we do it alone, or we also incorporate? If they want to also incorporate it, yeah, for fine and good. Now you said for it's good for medical students, about the core physiology. And when I did on my undergraduate days, we did pharmacology in our fourth year, our third year and our fourth year. We had pharmacology taught by physiologists. You can imagine that. Yes, completely taught. We were just made to cram drugs, pharmacodynamics, pharmacokinetics. We had no understanding of it. We had no understanding. But now, if you incorporate this, you we have physiologists who are also tending towards clinical physiologists. So if you exclude these things from these first 4 years basic, and then you are sending them for internship, like Unizik, for example. If for example Unizik is not even incorporating things like this, by the time you graduate a physiology students and then send this physiology student to the hospital for internship, what are they going there to do? What are they going there to compete with the house officers and compete with the med lab scientists? What are they actually going to do? Everything is new. Everything is strange. They know nothing. So it's time it's time physiologists should, I think for me, I think it's time we need to broaden our horizon. We need to go deep. We need to learn these things. An average physiologist know nothing about is EEG or ECG apart from theory. But there are some of them who are the ones, they are some clinical physiology are the one handling them in the institution hospitals. So if they don't have this exposure, and then the IT that is part of the CCMAS, there's an IT that is part of okay, physiologists can go for IT or go for postings, whatever they want to do during that period. At least they can go to the hospitals and then further enhance the skill. And then during internship, they know where they can be posted to. So I believe even core physiologists, not just MBBS students, should also be exposed to these things. That is why we have physiologists who will come out after their first 4 years BSc. They are very, very confused, not knowing what to do. And then they fall back to doing masters, not because they really want to do the masters, because it's more or less their only option. So each PSN conference each year, the same question is still being asked. What is the future for physiology? What is the future for physiology? Physiology is dying. What is the future for physiology? It's not like every other natural science courses. So we need to really solidify this course. It's interesting outside. It's very interesting outside. We should also make it interesting. Otherwise, with time, we may not really have BSc students coming for BSc physiology, and finding interest in it. They may be doing it because they didn't give them admission for core medicine and nursing and the rest of it. No, people should go in, study it, and have good knowledge and decide, let me go into clinical practice in this aspect, or focus on EEG, focus on ECG, focus on that or that. So that's I don't know if I really have answered your question, Dr. Onalapo. Sorry if I got your name wrong.
Thank you. Yes, you did justice to that, at least. Thank you.
You're welcome.
Yeah, Dr. Cordilia, thank you so much. This is actually
Yeah,
very
thank you.
interesting. I think I'm going to ask a question, and I think I want to add one or two things. Just like you said,
Okay.
I actually did my undergraduate in Lautech, and we had a 5 years course. It was a 5 years course in Lautech, and we actually went through a lot of rigorous training. And I think that actually helped one or two people to be able to decide where they actually need to fall in. And for the upcoming generations, they call them the Gen Zs. When I ask the project students, what do you want to do? What is your next action? They'll be like, I really don't know. I'm not sure. Some will say, I want to go for clinical physiology. I'll now be asking them that, what is the difference between the physiology you are doing now and clinical physiology? They'll be like, no, they just want to be in the hospital. They want to be this. They want to operate this. They want to operate that. And I think these are just the basic thing that should have been taught from 100, 200, 300, 400 level, so that they'll be able to handle all this equipment, and it wouldn't look as if there's something special about the clinical physiologist that the main physiologist is actually not doing. Just like
Yeah.
Mr. Femi asked about the incorporation. Now, between us, we actually know that there is these discrepancies about being an anatomist, being a physiologist, and being a pathologist. I work in the hospital. You are a lecturer. How long do you think it's actually going to take us in Nigeria to be able to incorporate this? Because we've been on this for a very long time, trying to see if we can bridge the basic medical sciences with the clinical sciences. So do you think this is actually going to work out? Would some people still not try to truncate it working, even with the CC maths that we have, having a general curriculum all through the universities, either private or federal or public universities? So what do you think?
Sorry, I lost her somewhere. So you can give a recap. Are you there?
Okay.
Like,
Yeah. Can you hear me?
sorry, yeah, I can hear you now.
Yeah, my question is, knowing fully well that we have bridges between the clinicals and the basic medical sciences, we've been trying to see how we can incorporate the basic medical sciences and the clinical sciences coming together, but it has been
Yeah.
kind of not going forward. So how are you sure that this is actually going to work out, even with the fact that we have a CC mass curriculum across every university that we are doing the same thing? We have actually the same topics and modules to take for the student. So how do you think this can be incorporated?
Okay. All right. All right.
And
Thank you.
how visible is it?
Okay. Sorry. And how what?
How, how
Okay.
visible is it? Are you sure it would not die? As in trying to initiate this, do you think something that has a future?
Okay. Yes, I do believe it will have a future. First of all, we already know there's a struggle between medics, non-medics, and all of that in our institutions, and fighting for supremacy and who should be, who shouldn't be. But with something like this, we are everyone have their place. No one is fighting anybody. Everyone have their place. Okay, medics, you will handle the clinical aspect. You talk to the students on case in under physiology, sorry, under cardiovascular physiology. Now you handle or clinical presentations and cases. The physiologists will introduce the concept. We'll just define it. Not in some schools where you see, no, neurophysiology should be handled only by medics. This should be handled only by this. Core physiologists can take blood physiology, or you begin to give them other softer tissues. But when you give everybody their place, I think there'll be mutual respect and mutual understanding. That is exactly what I believe. Now, even in each department, we have medics and non-medics. For example, in physiology, already if there's that cordial relationship in each department, and some of these medics are also operating in the clinical aspect, even in the teaching hospitals. So when there's that relationships, for me, in our department, we do have that. And we can easily walk up to them and say, okay, we need Dr. This to talk on this particular one. Since he's also an internal medicine physician, let him speak on this. And there's very strong relationship between even physiology and internal medicine. So you see, most of the things they do, it's just an advanced physiology. They do serious, that's what some of them were discussed. They do serious physiology. So, and they even sometimes they will tell you these investigations are handled by physiologists in advanced system, not even the internal medicine physicians. So they work together with physiologists. As a matter of fact, if physiologists are to be posted or are to do postings or internships, it's in internal medicine, under internal medicine department. That's where they are exposed to you see physiology in action. This is complete everything physiology. They do work on spirometry, they work on everything, so give everybody their place, and nobody is fighting. It's like in a family you are saying, what is this fight for gender equality? Husband and wife are equal. Mm-mm.
Okay,
A
Dr.
man is the
Iyare,
man.
Dr. Iyare, we
Yes.
have, I know you will continue. Please just sharp answers so that we won't keep you too long. I mean, Dr. Ada is raising up his hand
Okay.
or her hand. So can you please unmute and talk?
Mm-mm.
Dr. Ada,
Okay. Go ahead and talk.
Okay. Hello, good evening, all.
Good
good
evening,
evening.
ma'am.
Hello, can you hear me?
Yes, ma'am.
Yes.
Okay, Dr. Iyare, thank you very much. I've always enjoyed your lecture. In fact, I always enjoy listening to you. Um, and
Thank you, ma'am.
this is one of those your beautiful presentation again. I think you're a born
Thank
teacher.
you. Thank you, ma'am.
Okay, thank you very much. I just want to make a remark um, about this interdisciplinary collaboration in physiology teaching. For me, I know that normally in with the whole load of work, people have this sense of don't add anything extra to what the load of work I still have to do. But I know with interpersonal relationship, we can bridge the gap, and that is building strong interrelationship, especially when it comes to crisscrossing departments to bring specialists, like you said, from other areas to handle their area of specialty and bring it in and incorporate it into our main lecture with strong interrelationship. It will go seamlessly. Yes, you mentioned that it can be incorporated as a policy, which makes it binding on them. But um, I think if we are able to build a strong, can you still hear me?
Yes, ma'am, we can hear you.
A strong interrelationship with our colleagues, we can always reach out to them and bring them in. And of course, everybody is always excited to come and talk about what he knows best how to do or his area of specialty because he will really shine there. Um, in the PG program we were running, I had to do something like that with our biostatistics because I know that we have always, like when I did biostatistics, it didn't make any meaning to me. They will come and bombard you with figures, tell you all the stories you can't even join together. All you do is to chew their handout or chew their material and then spew it out on the exam day and then run away as fast as you can. If you land safely, God has saved you. So I wanted a relationship where I can bring in somebody who really knows, this thing and have used some of these packages very well in solving problems. And that was exactly what I did to bring somebody who was very good in these and who could dissect it to the understanding of the students better than just bringing somebody that would just come and give us dry talks on what he doesn't even understand. Just he's just doing it as loyalty to the school that he has been assigned to teach that. Not that in fact, when he's teaching, you will know he doesn't even understand what he's talking. So, and that was what we did. And I believe the student had a good time. We made it a hands-on teaching, wherein they brought in their laptops. I never had it that way. We just do all on the board or on the paper. But this time we brought in our laptops and ensure the students run the programs themselves. And the excitement of seeing that what the teacher is saying that right on your laptop, you are fine getting the result, same result is getting can make it very
Yeah,
exciting. So that was
yeah,
what was done in that course, and it was very interactive, and I believe the students enjoyed it more, unlike what I had in my time. So I believe, and it was through interpersonal relationship. Um, I believe that if we can build up strong relationship and we can always reach out to them and they can also reach out to us in our area of strong points to come in and shine our best and beef up their lectures. I think it's what it can be done. It can be done. Thank you very much.
Thank you, ma'am. Thank you, ma'am.
Thank you, madam. Sorry, moderator. There is the Dr. Ibrahim is raising up his hand. Maybe you can unmute. But there was a question. Okay. Yeah.
Okay.
There was a
Yes.
question on the chat.
Yeah.
Yeah, maybe he want to speak to the question. So
Yeah. So thank you very much for this
Okay.
presentation. We really enjoyed the presentation, and then I've been used to this kind of presentation for some time now, and then I felt we are missing out something um, from the way. I think physiology, particularly, is broad. We could have hello.
can hear you. Go ahead.
Okay. Yeah. I think physiology is broad because we have different core disciplines in physiology. We have the basic scientist physiology, and then we have the clinical physiology. So we should be able to define where we're tilting towards. So are we trying to bring up clinical physiology or then forget about the research aspect? Because I know we still suffer a lot as academics in Nigeria in terms of research progression and drug discovery. So because uh, our main reason or the main reason for establishing physiology program, I think, should be explanation of disease mechanisms. Because if you don't understand disease mechanism, then you can't understand how you develop a drug uh, for certain diseases. For example, because the clinician, for example, in the hospital, they are highly limited to disease conditions. Sometimes, like for example, like COVID-19 that just came and go, you can see how they struggle a lot there in the hospital, like trying to bring out anti-malaria disease because they cannot understand. They are not trained for that purpose. So we are trained for that purpose. So there is need for us to improve our discipline or our research capability in that direction. So I was thinking maybe it's possible to change the curriculum for our PG programs. For example, instead of 1 year, we can make it like 2 years, and then instead of giving them the advanced physiology courses for that 1 year, we can actually expose these particular students based on what based on the area they want to specialize. We can actually post them to the clinical area to study the kind of diseases available in that area, so they can understand that, and then give them possible assignment or CA or test like come up with a concept. So how can you explain these disease models in terms of in experimental animal, something like that, so then get awareness, so that we begin to train ourselves to see how we can be modeling disease mechanisms in Nigeria towards drug discovery. I think this is a key area we are missing out because most of us do not have capabilities for research in Nigeria. This is what I see. We are very good in teaching. Few of us are very good in research. Sometimes when you go to PG program, you see what they're presenting. You see they present topics like people studying in pharmacology. I think we should go far beyond that. This is my thinking all the time. Yeah. So I don't know what you see about it.
Okay.
Yeah.
Um, Thank you, Dr. Ibrahim. So, you didn't ask a question. If I get it, you're making a suggestion, right?
Yeah. A
If we
question,
can have, yeah,
a
on
question at the
the
same time. The question is why this topic on all the time? So why are we trying to like bring it a calculated program or try to tilt the student towards clinical applications? So if we do that, that means the time we come, we don't have basic scientists anymore because all of them want to be in the hospital. For that basic understanding, just want to make money or don't put on the white lab coat. I don't believe in this because if you do that all the time, then all of them are going towards that direction, and then physiology will die off. I think the physiology program was established for the basic reason to understand disease mechanism. And then we're still very, very far away from that direction, even currently. And then no one is discussing that. So the only thing we see ourselves discussing is like how to bring them into clinical settings. I think that's a missing point there.
Okay. I want my elders in physiology to correct me. I don't know if physiology is about I was taught that physiology is just all about disease mechanism. That should actually be, we actually do the functioning, the normal functioning, and then the deviation from that we'll now talk about the pathology. Anyone can, any course, any discipline can go into research. We just want comes out balanced, not just stereotyped, not just one-sided, lopsided. Yeah, like I said, doctors still come out, they focus on research, but at least an average MBBS graduate after the 5 years of training is balanced in ONG, in this, in that, in COMED. It's all round. So we want the physiologists to also come out balanced with solid foundation, and then with pillars. And then during the MSc, you can now focus on where to channel your mastery, either in research or in clinical clinical physiology, whatever the case may be. But there is need to build a solid foundation. There is need to get a solid, a well-grounded physiologist, both in research methodologies, both in clinical aspects, and in every aspect. For me, I don't think we should just only focus on and besides, I don't think physiology was raised just only for research purposes. Every discipline can also focus on maths, computer science. Now research is interdisciplinary. Have a research team with just only a physiologist. So my whole thought is for physiologists to come out very concrete, and they are the master's level. You can decide where to focus on. You can decide. I agree with your suggestion that there should also be a retouch of the curriculum for masters MSc physiology. If it should be extended, fine, and then they can have them focused on different areas, disease or what have you. So, but for the core physiologists, another undergraduates, they should come out well grounded. I didn't like how I came out after my first 4 years. So that's why I'm proposing this. People should come out not.
Okay, I think we are having um, a network issue. I hope it's not mine anyway. Can you
Don't
hear
know
me?
Yeah, the network
if the
is skipping.
question was
Okay.
answered. We can also.
I think it's back again.
Okay.
Hold on. Okay, can you hear
It's
me?
at her hand, right?
Yeah, I can hear
Yes.
you, sir.
Okay. Thank you very much, Dr. Iyare. I think these questions have become a national issue. You have the Clinical Physiologists Association and the basic people, and then there is these questions on are you going to overrun the main physiology for the focus on clinical physiology? But I think you are trying to establish a balance. And I think also that even for the CCMAS and the program, you see, we are already operating CCMAS now. And physiology BSc runs under PIO, and there are different courses. They are doing the same physiology, but they don't even put them in the same class. Physiology under MBBS run under
Mm,
PHS code.
yes.
So I think the most important thing is to know how to do curriculum switch, whereby because the physiologists are specialist physiologists, while
Mm,
the MBBS they are learning physiology for medical practice, and
mm,
so the focus and the trainee cannot adequately be the same one way or the other. So we must know what we are training one for and what we are training the other one for. And arising from his question, I say I have one question, but I think his discussion has brought it out that okay, in this proposal, I did not find a situation where you ask somebody to come from the laboratory. For instance, my lab is recognized as a center for modeling and training in Parkinson's disease. I think for all whatever I might have done, I should be able to come to the class and say, "Oh, guys, I do this research and this and honestly, I have some medical students, 300, 400 level, coming to back to me and say, we want to do research. We want that is our that's our skill set, our area of expertise. And then those who are BSc students also want to go to the clinic and learn one thing or the other. So we should be able to have that level playing ground. But I'm thinking that in your curriculum, I did not find where you actually recognize research, whereby product from research and researchers can actually come tell them. And that's what I'm doing now in my class. There's a course, neurophysiology. We've been doing Parkinson's disease, and I told the teacher, I said, look, I'm going to find a time to come and tell them what me and them, Dr. Patrick, people who are passing through my lab. In fact, if you ask Dr. Patrick, I think he's still here. Once in a while, when he was doing his PhD, I'll bring him to the class. Come and tell, even medical class, come and tell them what you are doing, how we are modeling and trying to solve diseases. So I think you should then consider how to incorporate the core basic aspect, which is research now, not necessarily teaching hospital stuff, clinical stuff. Yes, they are good, but let us also balance it, whereby we also bring what we have from the laboratory, bring specialists, scientists, researchers to come and also talk to the student. And I think it's a very good proposal.
Okay. Okay. Yes. Yes, Prof. Thank you very much. Yeah, that's why it's a proposal. It's still being proposed. So there's always room for inputs. There's always room for input. So I'll waiting for to get inputs today from questions that are raised, and I'm noting them. 3 or year 4, we do research methodology. So at least in that stage, for the core physiologist, at that stage, we can also always have people from the lab, people from research groups, and just
Yeah,
like yours to come
and
in.
I noticed something that in the presentation you seems to skip the role of physiology laboratory. There's a lot that can happen in physiology laboratory. I was in University of Ghana, Legon, and then they actually run consultancies. So even the teaching hospitals, I mean, some of the hospitals send people to physiology lab where they do these lung function tests, this and that. So we also have strength in physiology if it's properly managed. Not necessarily that you have to go
Mm,
to clinic before you do that, but the physiology laboratory is meant to provide some certain level of experience.
Mm. Yes, sir.
yeah.
Dr. Alagosi, you
Yes.
want to say one or two things before we go?
Well, Prof, thank you, sir. Sorry, sir. Prof used to be my teacher some over 20 years ago in West of Ilorin. And then
Oh, I don't know.
I think you might forget my name by name, but artificially you can recognize me. There was a time I came to your lab.
Okay.
Uh, I used to be student under Prof. Shaladwe, research
Oh,
student, and I'm a classmate to Prof. Alagbansi.
oh. Wow. Where are you now?
I'm in the UK currently. Yes, sir.
Wow. Thank you
I,
so very much.
yes,
It's
sir. I
nice.
came. Yeah, I came here for my PhD in molecular physiology, and then I
Okay.
focused on the molecular mechanism of skeletal muscle atrophy. So I finished
Wow.
3 years ago from University of
Wow.
Birmingham here. Yeah.
Wow.
But
Wow. Thank you.
I lecture with Kogi State University, Engba.
Okay.
Currently a
Okay.
senior lecturer. Yes, sir.
All right. Thank you very much. We're
Yeah,
happy to
thank
have
you,
you.
sir.
Thank you very
I've
much.
been I've been attending your program, sir. Yeah. Thank you, sir.
Thank you.
Yes, sir.
Thank you. Thank you. Dr. Lagos, talk. We cannot hear you. I know you're muted.
Can you hear me now?
Yes, we can hear you
Yes,
now.
sir.
Yeah, you can hear
Okay.
you.
Okay, I will say that I have nothing much to say, just to congratulate Dr. Cordilia for the good presentation. But just a few points on the curriculum approach, the integrated curriculum approach. Actually, there have been a lot of studies, educational research that have shown that curricula with integrated approach that she has mentioned, that she has emphasized, they yield better student performance. So I think it's high time many universities in Nigeria look into this, because teaching courses as a standalone subject, subject-based curriculum, it doesn't offer the best that the student deserve. So it's time that we start looking outside the box and see how some of these insights can be implemented. And maybe with that, there can be some educational studies in the Nigerian context that can test the efficacy of this structure of curriculum in physiology education. So, but generally, I commend her for the good presentation. Thank you.
Thank you, sir.
Okay.
Thank you,
Thank
sir.
you,
Yeah, thank you,
coordinator.
doctor. Thank you so much. And really appreciate you for coming online to give us this presentation. It's so wonderful. And we look forward to working together and try to make sure this works out. God helping us. And I think with this, you've really done so well, and really want to appreciate you. And thank you to everybody that actually came on board and gave their time and their contributions. Really appreciate you. Thank you so much.
Thank you, Dr. Cordelia.
Thank
Thank
you.
you, everybody. It's been a wonderful time.
Thank you, sir.
Bye-bye.
All right. Bye. Jesus.